So I'm going to talk about fetal pleural effusion, again talking about therapy and outcome. Again, this is something that's not always you see every day, but once you see this fluid collection in the fetal thorax, it becomes a problem if this effusion is going to resolve or not, if this is a large effusion that's resulting in atelectasis or hypoplasia, whether you need to do something about it. And again, it should be, you should make the difference whether this is a primary pleural effusion that's isolated, it's like a chylothorax, or is it part of a more generalized picture of non-immune fetal hydrops. Now, interestingly, this congenital chylothorax has been described in families, many publications in the literature. This is one from Taiwan talking about happening in 3 siblings in the same family. And the first things that you need to make the difference between when you talk about primary and secondary, these are the typical sonographic features. So primary is usually unilateral, it's usually isolated, and it can cause mediastinal shift with a mass effect and the risk of pulmonary hypoplasia or cardiovascular impairment. While secondary is usually bilateral, usually it's associated with other malformation, can be aneuploidy, can be cardiac defect, anemia, infections, and there is little or no mediastinal shift. If you remember this, then obviously it makes sense that probably you're going to act mostly, if you're thinking of any fetal intervention, on primary fetal effusion. This is one of the very recent case that I had. Actually, this is you can see it here, it's 8th of May. A 40-year-old gravida 2 para 1 that presented, was referred to us for an isolated left pleural effusion. And you can see here clearly that you can see the fluid around the lung, and you can see the diaphragm, and you can see that there is a mediastinal shift and the heart is pushed. And these are different further images at different plane. So basically, because she was 31 weeks at that time, we went through the minimal evaluation, confirmation of a primary lymphocytic effusion by cell count, and then we had a PCR-based infection studies to rule out infections, and of course we wanted to do a chromosomal analysis. Now, this is what I'm going to say, because this is quite interesting, because in this, maybe Bernard would be interested in something like this. This is a woman who early in pregnancy, at 40, because of 40 years of age, had an IPT. And she was a low risk for trisomy 21. And before sending, we didn't have any signs of infections on the ultrasound, so we decided to send for a rapid aneuploidy screen, and then if it's negative, to do the rest of the PCR for the infection. And interestingly, unfortunately, I would say, this came back at positive for trisomy 21. And this woman was very upset because she felt that this is not fair for her. She's low risk assessment. Her NT scan was normal. She didn't have an increased NT. She had an IPT that showed low risk. And we were trying to explain to her that this has been described. This is not something that's unusual. It has been described in women with isolated fetal pleural effusion. Sometimes it has been described with other things, but it is part of the workup. And then obviously we're not doing anything now, and she's still pregnant. She's almost 33 weeks now. So there is the good prognostic factor, which is like unilaterality and isolated abnormality with no hydrops, and a 10 to 20% chance of spontaneous resolution. And there is a poor prognostic factor when there are infections or chromosomal abnormality or progression in size or progression to hydrops or presence of hydrops, that is accumulation of fluid in other cavities. So this fetal pleural effusion or hydrothorax, again, it's easy to see. You can see here, again, compression of the heart, a major fetal pleural effusion compressing the lung and the heart, causing a mediastinal shift. But then what to do with these cases? Again, the poor prognostic factors for a primary fetal hydrothorax would be early gestational age at diagnosis, below 30 weeks, skin edema with ascites, and of course bilateral effusion. In this case, it's very obvious that we have a thickening of the skin and a major picture of hydrops, not only isolated. There have been many unusual cases of hydrothorax described. This is one case of bilateral agenesis of the superior vena cava that has been associated. Another one that has a chest wall mesenchymal hamartoma associated with a massive pleural effusion, and you can see it here, and you can see it, the 3D CT mass involving the posterior aspect of the right 8th and 9 ribs. There are cases of diaphragmatic rhabdomyosarcoma presenting with fetal fibros, where obviously the prognosis is very poor. And the reason I'm putting these unusual cases is again selection of patients for therapy, for intervention. So it's an easy diagnosis, but what's next? And again, I'm talking about isolated fetal pleural effusion. And again, this is coming from the center in Texas and Children's Hospital at Baylor College of Medicine, where this is they studied the natural history of fetal pleural effusion. This is their strengths is that this is a single multidisciplinary high volume referral fetal centers. So it's being managed by a specific team with a specific protocol how to do it. And this is what they had. They had an overall perinatal survival of 93% almost. And again, they started with 189 pleural effusion. Those who had high drops were excluded. Those who had secondary effusion with cardiac, lung problems, chromosomal TTS, and many infections were excluded. And they were left with 30 cases of primary pleural effusion. 2 were lost to follow-up, and they had the rest, 28. Those who resolved had 100% survival. Those who were stable had 100% survival. And those who were progressive had an 83% survival. So overall, you can see that the survival for this group of isolated effusion, it's almost one-third, one-third, one-third. One-third chance of spontaneous resolution, remaining stable or progressing. And they had a case that really dramatically resolved over a very short period of time, over 3 weeks, from 22 to 25 weeks. You can see clearly how this happened. And for them, this is an argument for being conservative and not to hurry directly for intervention, especially those who have, again, to satisfy the criteria for an isolated fetal pleural effusion and after excluding secondary causes. And this is their algorithm that they follow in Texas, where their antenatal evaluation, they would rule out infections, as I said, if there are any hemoglobinopathies. They have a detailed echo. They studied if there is any evidence of fetal anemia, a torch PCR. And then if they have a secondary pleural effusion, they manage according to the cause of the effusion. If it is idiopathic, that's primary. If it's unilateral and with a normal cardiac function or no high drops, whether it's large or small, they go conservative. And they do ultrasound 2 or 3 times weekly with no fetal intervention. If it resolves, it resolves. If the effusion remains stable, they will continue intensive monitoring and deliver according to obstetric indication. If the pleural effusion progress and their indicators of progression, either an impaired cardiac function, so they do routinely assess by fetal echocardiogram myocardial function, or there is evidence of progression to high drops, this is where they will intervene. And their interference would be either by thoracocentesis or initially, and then if it reaccumulates, they do thoracoamniotic shunting. And if this is associated with part of hydros with polyhydramnios, they do amnioreduction. And again, they continue the monitoring and deliver according to obstetric indication. So as you can see, there is no harm of going conservative in these cases. And actually, the 2 most important prognostic indicators would be if you have a congenital chylothorax, would be the progression to high drops, and if after birth you have an early onset pneumothorax, this would increase dramatically your survival rate or the survival rate of these neonates. Now, once you start doing intervention, as I said, it's not a bad idea to start with just a simple thoracocentesis before doing thoracoamniotic shunting. So the first one, which would be the diagnostic thoracocentesis and sending the fluid for the study that I talked about. And then if the fluid reaccumulates, to do the shunting. And you can see here in the, this is the outcome of 54 hydropic fetuses treated with thoracoamniotic shunting. The survival rate overall was 57%, and the preterm delivery was 71%. But when you look at survivor, the most important that you realize is that out of the 31 survival, 28 had chylothorax, which brings us back to the importance of making the diagnosis and talking about prognosis and the parents what to expect from in utero intervention. One had a right congenital diaphragmatic hernia, one had a Noonan syndrome, and one had pulmonary sequestration. So let me just talk again about the diagnosis and outcome in non-hydropic fetal pleural effusion. And I wanted to differentiate between a pregnancy presenting with the pleural effusion before 24 weeks and after 24 weeks. This is the outcome of pregnancy presenting with the pleural effusion before 24 weeks. And you can see that there is, if it is a unilateral with no additional anomalies, there is a 75% chance that this would resolve by birth. While if you have bilateral, a bilateral with no additional anomalies, or bilateral with additional anomalies, of course here you have an increased chance of having a chromosomal abnormality, and genetic testing would be really important because you have all kinds of both chromosomal and non-chromosomal syndrome. When we're talking about pleural effusion beyond 24 weeks, the story is a little bit different, because here the chance of a chromosomal anomaly become important even if you have unilateral with no additional anomalies, or with a bilateral with or without additional anomalies. But the most important in this study, at least, was the fact that some of these cases were diagnosed with what's called Noonan syndrome. And what really the study adds, this was published in Prenatal Diagnosis, that you can counsel patients that unilateral pleural effusion that present at less than 24 weeks have a good prognosis, and 75% resolved by birth. In fetuses with unilateral or bilateral effusion and no additional anomaly identified on scan, the chromosomes were abnormal in 13%, and hence the recommendation to obtain genetic testing and chromosomal analysis. And all cases subsequently found to have Noonan syndrome presented with pleural effusion at or after 24 weeks of gestation. And of all cases presenting after this time, 1 out of 5 have Noonan syndrome. This is something also to remember when you're counseling these patients. Now, about the shunting and when to put the shunt, this is again a severe left-sided pleural effusion with re-expansion of both lungs, and this is the shunt here that's showing, and there was a dramatic resolution of the severe left-sided pleural effusion and the mediastinal shift that was present before the shunting. You can see the shunt here, that's here. And when you look at the outcome following shunting, overall, because this is again a figure to remember based on the literature, overall, the survival with thoracoamniotic shunting is almost 50% overall. But it becomes very obvious that if you have hydrops, the survival will be much less compared if you have pleural effusion without hydrops. And it makes very good sense about this. Some of these women, some of these fetuses who are shunted in utero with isolated effusion without hydrop, the survival is almost 100%. So this is worth to remember. And this is one of the largest studies in the literature confirming to what I'm saying, that in 59 hydropic fetuses, the perinatal survival was 52%. In 29 non-hydropic fetuses, the neonatal survival was 72%. The hydrops resolved in 50% following shunting. And in the 22 neonatal death, almost every case had a reason for the neonatal mortality. So 7 were due to pulmonary hypoplasia, 5 had genetic syndrome, 2 had aneuploidy, and 1 was due to congenital heart disease. The complication of the thoracoamniotic shunting is not, this procedure is not without complications. Sometimes there is a displacement of the catheter in the cavity, or less usually in the thoracic cavity, in the amniotic cavity. And there is sometimes occlusion of the shunt, and the pregnancy loss is estimated at 5% compared to the initial thoracocentesis risk for pregnancy loss estimated at 0.5 to 1%. That's why it's always a good argument to start with the diagnostic thoracocentesis to get some studies on board, and then if you decide to do the intervention because of reaccumulation of fluid, you do you do the shunting. This is my last slide, the practice point, the selection criteria for pleural effusion treatment by thoracoamniotic shunting. Primary pleural effusion etiology, a normal karyotype, absence of other significant congenital anomalies, negative viral studies, normal echocardiogram, a rapid recurrence of the effusion after thoracocentesis, and a gestational age of less than 32 weeks. And this is the algorithm that you can follow, that many places do. So the diagnostic evaluation starts by determining whether this is a secondary or a primary. In case of a secondary with a life-associated threatening anomaly, you offer termination prior to 24 weeks. Otherwise, you follow to term. In case this is a primary fetal hydrothorax, and there is a response to the thoracocentesis, and it resolves, you follow to term. And if there is rapid accumulation, you go for thoracoamniotic shunting and again serial ultrasound, and you deliver a term. Thank you very much.
Thank you.